Dear colleagues, today we're talking about the management of periimplant soft tissue with a 3D collagen matrix. And when alveolar ridge resorption occurs, the surface of the attached mucosa of the ridge decreases, and in fact, a large proportion of patients with mandibular atrophy have a minimum area of support for the prosthesis, and pre-prosthetic surgery is a available method for enlargement. A way of increasing the stability of the prosthesis in these circumstances is to deepen the vestibule by lowering the connection of the mucosa and muscle. We call it vestibuloplasty. And in general, this surgical procedure is primarily used to optimize the jaws for prosthesis integration. And of course, the secondary objective of the vestibuloplasty might be to increase the height of the residual alveolar ridge, and in cases of bony atrophy, or to generate a sufficient band of keratinized mucosa around teeth and of course around dental implants, as to be seen here in these two cases where there's a lack of the sufficient mucosa. Well, it's generally accepted that the firmly attached keratinized mucosa surrounding implants and the implant abutment is thought to provide additional protection against mechanical trauma, and inflammation of soft tissue can result in periimplantitis with, we all know it, the marginal bone loss or hyperplasia of the surrounding mucosa. Functional periimplant soft tissues reduce the incidence of infection around implants and of course give rise to a favorable red-white aesthetics. As to be seen here, well, the risk of periimplantitis increases with less stable soft tissue types. Like, you have less risk for periimplantitis if you have fixed and keratinized mucosa around the implants. It's not that good if it's fixed but non-keratinized, and the least favorable thing is to having the soft tissues moving with the lip. Here we see a case of ours. Of course, it's in some cases you have iatrogenic loss of fixed mucosa. In this case, I showed in the last webinar, we did augmentation of these lateral deficit in the mandibular posterior area. You see, we did augmentation and shell technique with the cortical shell together with allergenic spongious bone. You see the fixation of the plate, of the cortical plate, with 2 screws, and then we put a collagen membrane over it. Over the collagen membrane, the PRF membrane, because it's known that the soft tissue healing will be better when using PRF. This is the result we saw after 6 months. So we have a stable new bone formation, but of course we have a problem now because of the implant placement. The implant is good; it's a diameter 5 millimeters in diameter, so there's enough bone for the implant. But if you see now, we have problems with the soft tissue, because this is a Lugol stain, which stains the mobile gingival tissue in dark brown and the fixed tissue in less dark brown. And you see we have not a sufficient height of fixed mucosa. We have less than 1 millimeter, and in this part there's not even 1 millimeter of fixed mucosa, just because we had to do the closure of the augmented site. So what can we do? There are various approaches for vestibuloplasty now, and they have been developed since, I think, 1935 or something. And during the last 2 decades, a routine approach for vestibuloplasty has been the free gingival graft. This approach requires a graft from a donor site, of course, usually the palate, as to be seen in this picture here. And this type of graft of course, increases the morbidity, and of course there are surgical related risks, such as damage to the nerve. There might be periostal necrosis, and there might be also, in some cases in the literature, I've never seen it clinically before, osteomyelitis in the donor site. When the graft covers a large surface, sufficient palatal tissue may not be available, and vast bleeding from the artery may occur. This is a result 6 months after grafting, after vestibuloplasty with such a graft, and you see good results. They are functionally good. From aesthetic point, they are quite good. And if you look at this, this is a cancer patient. We did vestibuloplasty around the implants, and these are the results after 1 year. And you can see that the functional results are really good, looking at the Lugol stain at this implant site, but the aesthetical results are not so good if you look at the long-term follow-up. So here you see that there's still the color is not the same as to be seen in the local tissue. There are slight differences. So at the beginning, from my experience, at the beginning the palatal graft shows very good aesthetics, but it changed a little bit during the time. In the literature, it has been shown that thickness of 0.9 millimeter is sufficient, but a little bit thicker graft, 1 millimeter to 1.5 millimeter, is the optimum for good stability. But for the aesthetic results, you might have to use even less thicker grafts. This here was the one graft I showed before of the 30 days, and this is a graft after 180 days. And again, you see the difference in aesthetics. Another possibility we often use for big grafting sites, skin grafts. They have been used as good alternatives since they encounter no problems, or nearly no problems, with shrinkage and scars, which are unavoidable in the secondary epithelialization process. Studies show a high level of satisfaction in patients with vestibuloplasty with partial thickness skin grafts. And when used in the mouth, the skin has associated problems that lead to patients' disaffection. It has to be seen here. The functional result is quite good, but it has a different color, and the texture is different from normal mouth epithelium, of course. And in the first years after grafting, there might also be a bad taste or odor, probably resulting from the presence of hair and glands in the graft, and maybe also from insufficient oral hygiene. And there's also a development not of scars in the mouth, but scars at the donor site, and they're also a certain kind of discomfort. Well, this is how we do these grafts. So you have here, this is the leg, the upper part of the leg, and then you have this shaving instrument. Yeah, you just shave the partial thickness graft from the leg, and then you can use it for vestibuloplasty. Once again, it's quite good to be used at large defects, as to be seen at this one. Of course, it's nearly not possible to do this with palatal graft. You need really a big graft to cover sites like this, especially in patients after cancer or in patients after trauma. Here you see once again a result after skin graft, a small skin graft. You see there are slight differences in color, even if the results, the functional results we encounter are quite good. Once again, this is after healing of 2 weeks, a large skin graft, and you see there was a big thing to be needed, and well, it works, but it has its own problems. When looking at the literature about skin grafts, you see here that there's one publication I found, 3 patients after 13 years, and they found out that looking at the clinical and the mycological and the radiological examination, the results were stable. And this is also my own experience. We have stable and good results, but with the problem. This is a case of my boss, and this is a case of my own. We have the problem of the not that favorable aesthetics. Another possibility is using membranes, of course. One membrane, we use allergenic bones, so why not using allergenic membranes? Meaning that this is skin taken from human donors. It's cleaned and then used for vestibuloplasty. So there's one publication from 2012, and they did a split mouth comparison, the allergenic membrane versus buccal mucosa, and they found out after 1, 3, and 6 months that the shrinkage was similar. And they had a quite good gain of oral mucosa of about 4 millimeters. There were no differences between the two grafting materials. Of course, when taking buccal graft, you might have the scars, you might have problems with the glands. There are several problems you will face there as well. Well, one of the major challenges after the vestibuloplasty, of course, is to reduce the post-operative discomfort, like scar contracture and subsequent, perhaps even loss in the sulcular depth. And as I told you, skin grafts have been most commonly used to cover the exposed periostal surface, but we saw it, they have their own disadvantages. There's these Mucoderm, which is a 3D soft tissue graft derived from porcine dermis, and it's said to support revascularization and fast soft tissue integration, and is a valid alternative for patients' own connective tissue. After placement, the patient's blood normally infiltrates the membrane through the 3-dimensional soft tissue network, bringing host cells to the soft tissue graft surface and starting the revascularization process very fast. So significant revascularization can begin after implantation depending on the patient's healthy structure. Well, the Mucoderm offers a stable alternative to autologous connective tissue for many soft tissue grafting indications, and most of all, it does not require surgery at the donor site. So it might offer advantages over mucosal grafts, such as the decreased bleeding and post-surgery complications, and of course it is unlimited available. So let's go to the literature. What you see in the literature is you have several publications by Christian Schmidt from 2013 and 2015 comparing membranes, not the Mucoderm, but the bilayer membrane versus palatal graft. And they found out that the membrane has aesthetic advantages over the palatal graft, especially in the long-term follow-up. So at the first study, you just see that there's a similar gain of fixed oral mucosa, there's a similar shrinkage, but if you look at the long-term results, you have nearly the same shrinkage, but an aesthetic advantage. In another study, they just used the membrane, the 15 patients with these bilayer membranes up to 1 year. They found out that after 8 weeks, the epithelial growth is completed so far. The shrinkage was calculated to be about 44%, and the gain of oral mucosa was 3 millimeters, which is quite sufficient. We know from natural teeth that we need at least 2 millimeters of fixed gingival tissue. You get 3, well, when using the membrane, so it's quite good. Daniel Thoma also conducted some studies in 2009 and 2014. In the first, these are systematic reviews and meta-analysis. In the first, they found out, well, doing a vestibuloplasty is better than not doing a vestibuloplasty if needed. That's interesting. You will have more shrinkage when using alloplastic materials, just as like the membranes, and the main shrinkage will happen within the first year. Well, I think that's common knowledge now. And the other one in 2014, they found out, of course, the oral mucosa transplant, the palatal transplant, is the best documented with the highest rate of fixed gingival tissue. But the membrane will achieve at least 1.8 to 2.3 millimeters of fixed gingival, which is sufficient with a shorter time of surgery and, of course, less morbidity. So we conducted a study. We asked us, is there a difference between these B-layer membranes and the mucoderm membrane? The mucoderm membrane is thicker, so we have the bilayer membrane is about 1 millimeter when wet. The mucoderm membrane, the 3D matrix, you see the difference here. This is the matrix and this is the bilayer membrane. The 3D matrix is a little bit thicker and the resorption takes significantly longer. So we have mucoderm takes 6 to 12 months and the resorption of the bilayer membrane is about 2 to 3 months. So we ask ourselves, what about, do we have a better barrier function? Do we have a higher stability? What is the effect when using this membrane for vestibuloplasty? So going to the study, well, we wanted to use this membrane for vestibuloplasty in a prospective clinical trial. We are finally done with this trial. We had 40 patients in it. All of them had an insufficient depth of the vestibule and the width of fixed tissue of less than 2 millimeters. So all of them really needed a vestibuloplasty for different reasons. We developed a protocol preparing the epiperiosteal bed covered with mucoderm in 20 patients. Then the mucosa was adapted apically with sutures. There were no apical sutures to the membrane, and we used a splint for 7 to 8 days. And we compared this to skin graft, as shown in the slides, and compared it to gingival to palatal graft, also in 10 patients. This is some pictures you see here. The epiperiosteal preparation of the bed. Then we had to put the gingival tissue down, putting in the membrane. This is the membrane. It's really quite thick and it's good to handle. Then suturing the membrane. It's most important that you don't suture the membrane at the apical part. No sutures, just lays there. The apical, the gingival tissue is sutures to the periosteum, but there are no sutures to the membrane. So when moving the lip, there's no moving of the membrane. It just stays there fixed. So we come to a video. We did a video. You see here, this is the same patient I just showed you the pictures of. So we have fixed, this is also the same patient we saw on the first slides. We have the incision. There's a slight little part of fixed gingival tissue of about 1 millimeter, less than 1 millimeter. So this is the preparation of the epiperiosteal bed. Usually we do blunt dissection now, sharp incision, then blunt dissection, putting the tissue down. All epiperiosteal, of course. In this case, we decided to mobilize the fixed gingival tissue a little bit so we could put the membrane through. You will see it later. This is the suturing of the membrane of the gingival tissue to the periosteum. Sometimes it's difficult to handle the membrane when it's wet. It's quite good to do it, but it's not that stable. So sometimes we use this as a kind of just to have the correct size of the graft. Just taking an imprint then. You see, it's quite thick membrane you have. As I said, in this case, we used it to put it through, just because we hope to increase the thickness of soft tissue at this site as well. We used the cover screw to fix it a little bit at this part. Of course, it's not needed, just we tried it. So now the sutures at the crestal area and around the membrane. No sutures here. So that's it so far. The next thing we do is using this coverage, this wound coverage we prepared before. It's just a silicone material to fix it. The splint is removed once a day for cleaning, then put back. We had some cases without splint. It works without splint perfectly well if you use the correct sutures. But most of the patients, they feel quite better when having this splint just because of protection purposes. These sutures are highly recommended. They come from the periosteum, then go over the membrane to the lingual part, and so they fix the membrane at the bed. Once again, this is a problem. No, it's not a problem. But when we did the first cases, we were quite astonished to see these results. We thought that it's a complete failure. You will see these fibrin-like exudation, and to be honest, it looks terrible at this point of time. But if you go a few days ahead, you will see there's really thick new epithelium growing. This is the same patient. This was before. These are the results after 3 months. So you have a really thick and new fixed mucosa around the implant. These are the results after half a year. You see everything's stable. There's a lot of fixed mucosa. There's no mobile mucosa around the implants anymore. So finally it works, but you have to keep in mind that at the beginning, these first days, it might look a little bit strange. In the next patient, you see similar problems. The implants are also are already inserted, but you have these mobile gingival mucosa around the implants. What you do? Well, exactly the same. Preparing the epiperiosteal bed, suturing the membrane to the crestal part, no suturing at the apical part. And these are the results half a year later. You see that around the implants, before we had this big problem with the moving tissue, and with periimplantitis, this patient also received a periimplantitis therapy. And you see now the vast amount of new fixed mucosa around the implants. Here the staining with the Lugol was quite difficult to take the photo, but you see that there's no moving, no mobile gingival tissue around the implants anymore. In another patient, you see the same. We have the problems here. Fixed. There's nearly no fixed mucosa there. It's all brown when using Lugol staining. Again, preparing of the bed, just short to show you some cases. And these are the results 3 months later. So you have a vast amount of new fixed mucosa for your implant, for your prosthesis. So what are the final results of this study we conducted? Well, we saw that the collagen matrix, and again, you see it, look at this picture. if you look at this, you might think the whole thing was an absolutely failure. But if you're looking at the late results, then you see everything is working fine. So you have to keep in mind this will happen when you use these membranes at the beginning, but it's not bad. It works. So what we saw is that the new mucosa growing under the membrane, which is a barrier, which is for protection. The new mucosa is the same as in the local tissue. We did not see any complications, just like inflammations, dehiscencies. We have, of course, no scarring from donor sites, but you have to keep in mind, we have this fibrin-like exudation, and we saw it in the mean of 10 days. It's between 7 and 13 days, you will see this. But it will change within the second or third week drastically. Somehow it makes bath, and it looks good. So we have a mean plus of attached gingival in these 20 patients of 2.5 millimeters, 1 to 4 millimeters. This is quite good. These are the results of the 1 year, to keep in mind. So the main shrinkage has occurred now. In the histology we took, there were only remnants of the membrane to be seen, which were fully vascularized. So there's integration of the membrane, of parts of the membrane, without any foreign body reactions or something. And the shrinkage, we took photos before, photos while doing the surgery, and photos 1 year after. The mean shrinkage was about 34%, which is in accordance to the literature. If you compare it to the skin graft, well, I think most of you don't do skin grafts, but in universities we have problems. We have problems because we need that vast amount of skin. So of course the new mucosa was different to the local tissue. It was. We also had no complication in the mouth, but we had complications, of course, at the leg. So there was scarring. There were a discomfort for the patient. We did not see the exudation we saw when using the membrane. So, but we had a slight feature. The patients felt a little bit uncomfortable with this, with a mean plus of attached gingival tissue of 2.1 millimeters. Also quite good. It works. With less shrinkage compared to the membrane, 25% comparing to 34%. So when using the membrane, you always have to do a little bit over augmentation. Look at the palatal graft, which is, I think, the most interesting thing. Of course, the new mucosa growing there, you saw this case. This was just about 1 week later, 1 week after surgery. The new mucosa was similar to the local tissue, but it turned out to be less good after about 1 year. Then somehow the color changed, so I would not recommend to do palatal grafting in the frontal area. Also, there was no scarring in the mouth, or in the mouth, of course, because it was taken in the mouth. Significant less exudation compared to the membrane. The mean plus of attached gingival was 3.2 millimeters, which is really good. And the shrinkage was also similar to the skin graft, but less than when using the membrane. These are just results. You saw this result before. This is a membrane result. This is a palatal graft result. And this is a skin graft result. You see the differences in color when using skin grafts, of course. So when putting together, well, we have talking about these points. The first point, which is interesting for the patients, is donor site morbidity, of course. You don't have donor site morbidity when using collagen matrices, of course. We have donor site morbidity when using skin grafts and when using palatal grafts, so plus point for the membrane. Availability, it's available, you can buy it, the matrix, it's available, the skin graft available in huge dimensions, palatal graft, let's say less. Aesthetics, we found out the best aesthetics, really the best aesthetics to be seen when using the collagen matrix. It was less good, it was not very good when using skin grafts, and the palatal graft was good at the beginning, but turned out to be less good after this 1 year. Well, the thickness of the pedicle graft was the best. It was just very thick. The volume was good. It was less good when using skin grafts or collagen matrix. I called the next thing side effects. So the side effects of the collagen matrix are these exudation thing. You see it, and somehow when you see it for the first time, it might scare you. For the skin graft, you have this feature, you have the discomfort of the patient when having skin, even with hairs in the mouth. And the palatal graft, the only side effect was the donor side mobility, and of course the changing of the color. But the least side effects were seen when using palatal grafts. So attached gingiva was seen in all cases. It's possible to gain attached gingiva in all cases of at least 2 millimeters. The best result was to be seen with palatal grafts, when you're looking at the height. And the shrinkage also was the least when using palatal graft, followed by the skin graft and then the collagen matrix. So if you put this together, well, for us at the moment, this collagen matrix is a viable and reliable alternative for vestibuloplasty. And why is it favorable? Well, it's minor mobility, of course, for the patient. This is of high relevance. It's available. The surgery, of course, it's much shorter. The aesthetics are really good, so we recommend it. We really recommend the usage of these membranes in the anterior areas, and we have a high rate of attached gingival tissue. Of course, one problem is the costs. The patient has to pay for the membrane, but they have to pay for the additional surgery as well. At the moment we have a lack of long-term results when using these membranes. It's difficult to have long-term results of longer than, let's say, 1 year. At the moment we have 1 year results. We will wait now for the next years. The stability at the moment turned out to be good, and we did not see any peri-implant changes. But we don't know what will happen within the next years. So this is a picture of my current hometown, Rostock. Thank you for your kind attendance, and I think that we might go to the questions now. The first question was, do you give prophylactic antibiotic therapy and chlorhexidine before this? Yes, we do. We give, before surgery, half an hour before surgery, we start with antibiosis, and we do it for 5 days. Normally, we use amoxicillin plus clavulanic acid. It's in the morning and in the afternoon, and chlorhexidine mouth rinsing will be used 3 times a day. So this is of high importance, the cleaning procedures. Also, you have to keep in mind that all the patients in this study, we did really close follow-up. So after surgery, we saw them at the first day, the 3rd day, the 7th day, the 2nd week, the 1st month, a lot of following visits. So we really had to show them how important the oral hygiene measurements are. The second is, how can we tell that mucoderm would develop into attached mucosa? For as far we know that being attached is a matter of the direction and density. Well, this is a really difficult question. And honestly, I don't think that the mucoderm itself turns into attached mucosa. I think that the mucoderm, it gets integrated. A small part of it gets integrated, but the whole thing is more a protection against bacteria, against everything from the mouth. So it's a protection, a shield, and under the shield the epithelium will grow undisturbed. So what we see from my point of view and from the histology I've seen, we just we protect the oral environment within this epiperiostal bed to regenerate itself. And that's why the tissue also looks so stunning good. Can we use socket shield technique to be used with collagen matrix? Well, honestly, you can. We did it in several cases. So we did the socket shielding and we put over the membrane. I did it in cases in which I did not want to do periostal splitting and destroying the vestibule. Just put on the mucoderm membrane. It worked perfectly, but I can only tell from a few cases, like 3 or 4 cases. So don't know if it works in every case. The flap in the video was partial thickness. Yes, it was. We do partial thickness flaps for this. Yeah, because you need the periosteum needs to stay at the bone. Otherwise it will not work. You need the periostal. The periostal part has a high capacity of regeneration, and you need this capacity to have the growth of new epithelium. The next question is, do you have any experience in using collagen matrix for root coverage? Honestly, I don't have. Sorry, never did this before. It's not my. Some colleagues at the university are doing this. We are mostly doing the larger surgery parts, and the root coverage is more into the conservative dentistry department. I don't know. The next question is, should mucoderm be always fully covered with the mucosa? What about some cases in which we do not have enough mucosa to cover the mucoderm? Well, it shouldn't be covered at all. That's not my point. I was showing that we prepare epiperiostal bed. Just you have the periosteum, then you use the mucoderm to cover the periosteum. Mucoderm just lays there. And there's no mucosa at all to be covered. You don't need it. It's just the new mucosa will grow underneath. In these cases, if you talk about like increasing, it can be exposed. Yes, of course. In all of these cases, in these 20 cases, it will exposed in all cases. That's why I said it's a protection. It's also exposed in these socket shield techniques. You just put the exposed mucoderm on the alveolar, on the hole in the alveolus. You just put it there, and it works. It can be exposed. Next question is, can it be used in combination with bone allograft? Yeah, that's what we do all the time. We use it together with allografts, but in allografts. I know, okay. So we do the augmentation we do with allografts, but not with mucoderm, sorry. If we have allografts, I think the main thing when doing augmentation is soft tissue coverage. And I would not dare at the moment to do the coverage with mucoderm, because it does not stay long enough stable to have the vascularization of the bone graft. So please, I would not try it. It's just, for me, it's too dangerous. I always do full coverage of the augmented bone with soft tissue. If this is not possible, we have a problem. That's why you need to think, before augmentation, you need to think of soft tissue coverage. Do not do it with mucoderm. You can do it when using socket shielding techniques or when using small ridge preservation techniques, but not with large augmentations. So basically, our next question is, so basically what it is saying is it can be used to increase the zone of attached gingiva. Yeah, yes, exactly. You just summarized the whole lecture. Exactly. It can be used for vestibuloplasty. Vestibuloplasty is needed in a lot of cases in order to prevent periimplantitis, for example, and it can be safely used for these purposes. That's possible. That's possible. You can use a double layer of Jason membrane, then coverage by mucoderm. It's possible you can do it, of course. My own experience is that when for vestibuloplasty, mucoderm alone is good. For coverage of larger bone augmentation, I do let's say allograft, then Jason membrane, then LPRF, and then soft tissue coverage. And with this combination, I have quite good results. I did not do big augmentations, membrane, and then leaving the membrane unexposed, exposed. I did not do it before, and I honestly I don't think it works. If you have any results of this, please show me. But I think that the most important thing when using larger bone augmentation is closure of the soft tissue, full closure. You need it for revascularization, for protection. Mucoderm is not enough. It's not enough for this. You can from my point of view. But please convince me if you have other results. So, are there any more questions? Quite lovely questions, honestly. Thank you so much. Thank you. Really, really good. So I hope you enjoyed the lecture. And I hope we meet soon and we meet again sometimes. And have a nice evening. Goodbye.
We would like to thank our speaker for sharing his knowledge and expertise with us today. We would also like to thank our sponsor for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You will receive an email notification with a link to the recording. Thank you again, take care, and goodbye.